Hello, and we're going to look now at the neuroimaging findings from the clinical case which Elsa presented earlier in the week. So if you remember, this was our 13-year-old border collie with progressive neurological signs. So when it comes to how we're going to image our patient, essentially when it comes to intracranial disease, we really have two choices, the choice of CT or MRI. To some extent, which modality we use really depends on what's available to us, and certainly CT can be quite useful for many intracranial diseases. Our contrast is based primarily on differences in tissue density, and so if we have diseases such as hydrocephalus or many cystic lesions, we can see those very nicely on CT. Obviously a lot of contrast between fluid and soft tissue. Many brain masses we can see quite nicely on CT, particularly if we give iodinated contrast media. And we can see that very nicely here in this example of a pituitary mass, which is enhancing quite avidly. And CT is brilliant for assessment of the bony structure, so very nice if we have osseous malformations or skull trauma. However, for many diseases, particularly some of the congenital malformations, inflammatory CNS disease, vascular brain disease, some gliomas, and cranial nerve disease, these are poorly seen or not visible at all on CT. And really, if given the choice, when it comes to intracranial disease, MRI is usually going to be better. And we can see a nice example here of a dog which has a parenchymal bleed within its cerebellum. We see it very nicely on the MRI, but the lesion is not visible at all on the CT. So, MRI for the majority of cases. We did MRI, the MRI was done on the case, and we'll look at those imaging findings now. Okay, so this is the MRI of our patient. So we have the transverse T2 weighted images top left, the FLAIR images top right, and then T1 pre and post contrast on the bottom. As we scroll through the images, we can see within the brain parenchyma there are multiple lesions. I think probably best seen on the T2 weighted image in the FLAIR. We see these multiple nodules and masses within the left cerebrum. There's a small nodule in the area of the pituitary gland, additional small left cerebral nodules, and a solitary nodule in the cerebellum. So we have multifocal disease, nodular and mass-like in appearance. One of the key things we need to think about is whether we think these are intraaxial lesions or extraaxial. These are clearly intraaxial. They are kind of globular in shape, centered within the white matter, and we can see the defining feature of an intraaxial location that we have cortical grey matter interposed between the largest mass lesion here and the calvarium. So, multiple nodules and masses, intraaxial. One of the important things to assess on MRI is the different signal characteristics on the different sequences, which will give us a lot of information about the underlying pathology and the tissue characteristics of the lesion. In this case, we have a rather unusual appearance to this largest lesion. We can see here that we have a fluid level. We can see the fluid on the T2 weighted sequence here, the CSF we can see is hyperintense, and this hyperintensity here, this linear area in the dependent part of this mass lesion. The FLAIR sequence shows suppression of this sequence, confirming that it's fluid-like or at least similar to CSF. If we look on the T1 weighted images, we have a rather unusual feature of this mass lesion here, in that we have this clearly defined T1 hyperintensity in this ventral part of the mass lesion. Now, T1 hyperintensity on a pre-contrast MRI is relatively uncommon and would often indicate that we're dealing with hemorrhagic lesions. So, when we have brain hemorrhage, the sequence we want to look at is the T2 star gradient echo. Here we have the T2 star gradient echo sequence on the right and the T2 weighted image for comparison on the left. So in this case, the T2 star gradient echo sequence confirms that these lesions are hemorrhagic. So here we see the typical appearance of intracranial hemorrhage on a T2 star gradient echo or susceptibility weighted imaging sequence. So hemorrhage will typically be signal void or very low signal, with this distortion and blooming, which is due to the susceptibility effects of the hemorrhage. So in this case, the T2 star green echo sequence confirms that these lesions are hemorrhagic, but also shows very nicely the increased sensitivity for this sequence compared to the fast spin echo sequences when it comes to documenting intracranial hemorrhage. So here we can see there's an additional lesion up here at the grey-white matter junction in the subcortical region of the right cerebrum, where there's this tiny hemorrhage which is barely visible on the T2 weighted image, but clearly seen on the T2 star green echo sequence. And another one here, slightly rostrally, will have this additional hemorrhage. So we can see that on the great echo sequence that there are numerous variably sized hemorrhagic lesions throughout the brain in this particular patient. The MRI appearance of hemorrhagic brain diseases can be quite complex on MRI. So the appearance of hemorrhage will depend on a large number of intrinsic and extrinsic factors. So it will depend on the age of the hemorrhage, the location, it will depend on the pulse sequence and the magnet strength, and also the underlying etiology. The key clinical question we're usually trying to answer is this malignant hemorrhage, so is it underlying neoplasia, or is there spontaneous hemorrhage due to such as hypertension or coagulopathy? In this case, the lesions appear very heterogeneous. We don't see a complete hypointense rim, which is often present with benign hemorrhages. If we look on the T1, the T1 hyperintensity periphery, which is due to methemoglobin, is incomplete. And on the post-contrast images, we see there are areas of abnormal, slightly nodular, heterogeneous enhancement in the periphery of the lesions. So these features would be a pointer that this is likely to be underlying neoplastic disease as opposed to benign hemorrhage. Benign hemorrhage due to coagulopathy, we'll see often evidence of hemorrhage elsewhere in the body. So often we'll have a clinical suspicion, so there may be bleeding sites elsewhere in the body. But in this case, the appearance of the lesions is more suggestive of a malignant cause for these hemorrhagic lesions. When we have intracranial pathology, it's quite important that we look for evidence of increased intracranial pressure and secondary effects which may be amenable to treatment. In this case, we can see there's quite extensive perilesional T2 hyperintensity, which is within the white matter and consistent with basogenic edema. And the combination of edema and the mass itself is causing this quite large midline shift to the right, so subfalcine herniation, and compression of the adjacent parenchyma. Assessment of brain herniation, so subtentorial and foramen magnum herniation, is best done on the sagittal T2 weighted image, and in this case the cerebellum looks relatively normal, and we don't really see any clear evidence of foramen magnum herniation or caudal displacement of the occipital lobes and tectum, which would indicate subtentorial herniation. So, based on the appearance of the lesions, my findings were multifocal hemorrhagic masses and nodules, which were intraaxial in location. We had extensive perilesional edema, causing a large mass effect with subfalcine herniation. And based on the appearance and signalment, my primary differential would be hemorrhagic secondary brain tumours, and of these, hemangiosarcoma would be probably the most likely etiology. So thank you, and we'll find out the outcome of the case from Elsa later in the week.